My name's Simon Rogers. This is the second of a short presentation on the patient concerns inventory, focusing on the outcomes and the results from a recent randomized trial. The first presentation addressed the why, what, who, when, where, and this is focusing on the outcomes. So what is the typical PCI profile? This is a slide from the very earliest paper that we published in 2009. And you can see that the common issues were dry mouth, fear of the cancer coming back, dental health, sore mouth, chewing and eating, fatigue, salivation. And you can see there's quite a tail down to items that appear relatively infrequently. But it's important with the PCI not to do item reduction and to eliminate items that don't come up very often, because these can be very, very important to the patient. And an example of that would be regret about treatment. And thankfully, regret about treatment is identified by patients very infrequently on the PCI. But when it is, it's something that needs to be addressed at that time to help support the patient in that regard. So even though some items will appear relatively infrequently, they can still be extremely important. This is the large international study that took place using a paper version of the PCI, 2,136 patients from 19 units. And there was international variations that you can discover when you access the paper. But again, the key findings here were fear of the cancer coming back, dry mouth, chewing and eating, swallowing. And the issue of fear of the cancer coming back is a very important one for the PCI, because as clinicians, we can't easily ask the patients if they have a fear of the cancer coming back. Because the patient may say, well, why am I being asked that? They may have come to terms with it. They may not want to be reminded. It may not be a concern. But if the patient prompts the issue of, can we discuss my fears of the cancer coming back? It provides a fantastic opportunity to reassure them in terms of their clinical examination, their symptoms, and also the likelihood of their cancer coming back. And that is a teachable moment that can be a repeated intervention, and we have published on that. In terms of what patients would like to talk about using the PCI in terms of early and late stage oral, oropharyngeal, and laryngeal subsites, we published on this in 2013. And I'm just highlighting this just for a little bit of overall information. So you have the early oral and late oral, early oropharyngeal, late pharyngeal, early stage laryngeal and late stage laryngeal, and then the other sides such as maxilla. What is the commonest item when we did this survey? And you can see that fear of the cancer coming back is very strong in this group. And then going down the top 10 items, dental health, chewing and eating, fatigue in the top 4 for the early oral. And of course, the mix of items varies a little bit by site and a little bit by treatment. And the other thing that I would just wish to stress here is if you look at the top 10 and you look at the frequencies, you can see that for late oropharyngeal cancer, you're still seeing that over a quarter of the sample are reporting fatigue and mucus production, even though it's down ranked 9 and 10. And of course, in the early oral cancer, where the treatment is much more straightforward, you can see that actually only the top 2 are in the 30% or more. So there's a huge variation in morbidity associated with the stage and the treatment. And this is reflected not only in the PCI items, but also their frequency. There's a lot more information on the PCI outcomes in the literature now, and the handle on QOL is a resource for that to get a more understanding of where and how it's been used and what the results were. And I want to focus on the randomized trial. The protocol was published in 2018. And basically, this is a cluster preference randomized controlled trial, allowing consultants to choose between either using the PCI package in their clinical consultations or not. It was a 2-center study between Leeds and Liverpool. And the intention was to aim for 416 patients across 10 consultants. And the primary outcome was the percentage of patients with less than good overall quality of life at the 1-year time point, as measured by the University of Washington. And then the secondary outcomes at 1 year was the socio-emotional subscale of the University of Washington, the distress thermometer, and health economic measures. The socially emotional subscale was chosen because, in principle, when the patient comes to the consultation, my hypothesis was that the fear of the cancer returning, the emotional impact of their cancer, was something that was not sufficiently addressed in the routine consultation without the PCI being an enabling tool. And therefore, potentially, using the PCI might see an improvement in the social emotional subscale of the University of Washington. Consultants using the PCI would get an output where it would list the issues that the patient wanted to discuss during the consultation as identified on the PCI, but also give a reflection based on the screening of the University of Washington as to which domains the patients were scoring particularly badly in terms of dysfunction on the University of Washington. And consultants were given the opportunity possibly to mention areas of dysfunction if they thought it was appropriate, as well as items specific to the PCI. In addition, patients could also identify members of the multidisciplinary team who they might wish to see and talk to. In terms of the baseline results, that was published in 2020, and the inclusion and exclusion has been very carefully explained. And at 1 year, we had this power calculation of the number of patients that we would want to have in the study, accepting that we knew that there would be some attrition from baseline to 1 year. So at the baseline clinic, which on average was about 103 days following completion of treatment, that's the first clinic consultation, and then the PCI would be used or not used in the subsequent consultations over that year. We had 288 patients in the study. We had aimed for 312, so there was a slight underpowering at that stage. We had 15 consultants, 8 using the PCI and 7 not using the PCI. And the study started at around 100 days following completion of treatment, and as I say, was used at each consultation following that. We looked specifically at the length of time it took for the consultations to take in both arms of the study. This was because there was a perception that by allowing patients to identify any number of 56 items and to have them brought into the consultation, this might lengthen the consultation and make the PCI tool unreasonable to use in clinical practice. At baseline, the PCI consultations were only 1 minute longer than the non-PCI consultation. We went into a little bit more detail regarding that and published a further paper in 2020. And of course, there was variation in the lengths of the consultations by consultant. And on the left-hand side, it's the entry consultants. And on the right-hand side, it's the leads consultants. And the average time in the non-PCI group was 10 minutes, and in the PCI group, 11 minutes. And actually, at 6 months and 12 months, the PCI consultations were slightly shorter than the non-PCI consultations. What lengthened the consultation were when patients had more issues to talk about and more problems, and that was reflected in the length of consultation being longer in those that reported a fair, poor, or very poor quality of life. In terms of the items on the PCI that led to longer consultations, the main ones were depression, mobility, vomiting, fatigue and tiredness, mucus, dental health, shoulder, pain in the head and neck, fear of the cancer coming back, and salivation. But the more items that are ticked on the PCI, of course, the longer the consultation tends to be. It's important that if the patient doesn't mention any items on the PCI, that can be a positive, because then one can focus on other aspects and one can talk about human things such as the family or the journey or other things that take away from the focus of cancer care and just make that consultation more human rather than having the reassurance that something isn't being missed. In terms of the main results, that also has been published at the end of 2020. Unfortunately, we had to close the trial slightly early because of COVID-19. This is a clinical trial, face-to-face consultation as an intervention, and also the psychology and distress of COVID-19. And during the first lockdown, consultations were stopped and there were no face-to-face consultations. So unfortunately, the study closed early with 100 patients in the PCI group and 105 in the control group. In terms of the number of PCI items at each consultation, there was a median of 5 at baseline, 3 at 6 months, and 2 at 12 months. And this is the typical profile of the PCI group with, again, dry mouth, dental health, fear of the cancer coming back, pain and fatigue, salivation, scoring very highly in this group. In terms of the primary outcome, percentage of patients reporting fair, poor, or very poor quality of life, there was a difference between the two groups, with 30% at baseline in the PCI dropping down to 22% at the 1-year time point, compared to 27% in the control group, dropping down 2% at 1 year. However, when one looks at the other factors involved in terms of the case mix, actually the estimated risk ratio at 12 months was 0.83. And similar adjustments regarding the absolute risk gave an estimate of 4.8% in favour of the PCI over the control group, with a 95% confidence interval, ranging from 2.9 against the PCI to 12.9 for the PCI. In terms of the socio-emotional domain, there was a difference between the two groups, and after a full case adjustment, this was statistically significant at 0.04 in favour of the PCI. Interestingly, in the PCI group, all of the domains of the University of Washington improved and were better than the non-PCI group. However, for each individual item, one could argue that caseness is achieved at a score of 10. And across the domains, even though there was an improvement allowing for case mix in, for example, pain at more than 7, it didn't reach that value of 10. In terms of distress at 12 months, the distress thermometer score of greater than and equal to 4, although there was an improvement, there was no significant difference between either group in terms of distress. Another aspect that's really important to the clinical trial is the health economics, and I'm extremely grateful to the team at Bangor University and also to Sherrod Semple for doing qualitative work with interviews for the consultants who were involved in the PCI arm of the trial. This group will make video clips available for us to better understand the health economics of the study, and it's not really within this presentation that I want to unpack these. However, I will say that the PCI proved to be a very effective intervention that had a good health economic profile. In terms of the consultant feedback, they felt that there was minimal training involved, and this often just involved a 20-minute small tutorial or a one hour group discussion. They felt it enhanced the consultation, it was easy to use, it was something that could be used flexibly in the consultations. They felt that no issues that the patient identified were inappropriate, and they could help talk about these and manage these, stop. They found the PCI helpful, and it enabled streamlining of the consultations, giving the consultations more focus. I have stressed the fact that it is a very low cost intervention and a way of improving doctor-patient communication. In terms of the main barriers to the implementation, even though we have level 1 evidence of benefit, it's still difficult to change clinical practice and the historical way that consultations are performed, and more work is required to get clinical buy-in. Also, the use of the PCI will be enhanced through better IT infrastructure, particularly if one is going to be using the PCI remotely at home with the patient. There are available resources to draw reference to, but I would particularly mention the Faculty of Health and Social Care and Medicine at Edge Hill, as well as the Liverpool Head and Neck Centre at the Liverpool University. And although this website link at the bottom is active now, over time that will change, but a web resource is available for those who are more interested in finding out about the PCI. Thank you very much.